lovely OTs, it's your girl Nancy. I am back again with another video. Now this video we are going to talk all about stroke rehab and the role that OTs play in stroke rehab. So if you are interested in this video, stay tuned. So before I get into exactly what OTs do when it comes to stroke rehab, I wanted to give you guys a little background as far as the neuro part and the science part of stroke and what happens when someone gets a stroke. Just so you guys know, stroke is one of the leading causes of disability in America, and it's important for us clinicians to be able to understand stroke and what happens and how to rehab, because there's a lot of people that deal with stroke. I, on a personal level, have someone in my family who has been dealing with stroke, so I know firsthand what it looks like, what it presents like, and the different things that goes along with it. So basically when you get a stroke, it's like you're having a heart attack but in your brain. It's literally a brain attack. Our brain is like our masterpiece, okay? It's our the boss of everything that we use. Our body, our brain, it's like everything comes from our brain. And because our brain is so important and it allows us to do everything that we want to be able to do, it needs a lot of nutrients, it needs oxygen, it needs blood, okay? So these nutrients and oxygen and blood that flows to the brain, it flows to the brain through these long lines, literally, or long tubes called arteries, okay? That's where your blood and oxygen run through to get to the brain, to supply the brain so that the brain is able to function properly. Now, whenever there's any kind of problem causing the blood and oxygen to not be able to flow to the brain to supply the brain with things that it needs to function, then you can get a stroke. Two ways this stroke can happen, okay? It can happen either through a bleed on the brain, okay, through like a rupture that happens in the brain, or it can happen with a blood clot, a block, any kind of block in the tubes. Whenever this rupture happens or block happens, what happens is that the brain is not getting sufficient blood and oxygen. Therefore, that part, wherever part in the brain that is not getting sufficient blood and oxygen, basically the cells in that particular part of the brain will die, depending on how long that the brain is going without blood and oxygen. And then the third type of stroke is called the TIA, or what I call the mini stroke. This happens when any part of the brain is without insufficient blood flow or oxygen for a very short period of time. So this is not a full-blown stroke that you are without blood or oxygen for a long period of time. This happens very quickly, and then the blood flow continues right after that. So usually some people may experience some symptoms even with that, and also it's a huge indicator that you may get a full-blown stroke or an actual stroke if you don't do something about it, or if you don't make some changes as far as lifestyle changes, okay? The brain is divided into two, okay? There is a right part of the brain and then the left side of the brain, okay? So it's two halves put together, okay? Now, the right side of your brain controls the left side of your body, and then the left side of your brain controls the right side of the body, okay? So it's kind of like a crisscross motion going on. And so whenever a patient experiences stroke on the right side of the brain, they can see the effects of the stroke, the symptoms of a stroke on the opposite side of the body, okay? And the same thing, if you experience stroke on the left side, you will see the symptoms appear on your right side of the body. So your right side of your brain is more of your creative side, doing the arts and music and stuff like that. As far as your vision, your confidence, impulse behavior, all that stuff is on the right side. And then when you go to the left side, you have more of your serious side, okay? This is where your logic comes in, doing math problems, your knowledge, your speech. All of those things comes from the left side of the brain. So like I mentioned, not only that the two halves have different functions, but different parts of the brain also perform different things. Depending on where the stroke took place, on that specific part of the brain, you will see different symptoms, okay? So for example, your vision is usually on the occipital lobe, which is back here, as well as your balance is at your cerebellum, is what controls your balance. So if you have a stroke back here at your occipital, most of the time you're going to experience some vision loss. If you have stroke somewhere around your cerebellum, you would definitely have a balance problem. So those are just two examples to give you. There's plenty of different things that can happen depending on where the stroke took place. So the damage or the extent of the stroke and the symptoms that you would see in your patients would depend on where the stroke happened, how long the stroke happened at that place, how long did that particular place or area in the brain go without blood and oxygen, okay? And also, is it happening on the right side versus the left side, for example, okay? So just keep that in mind. I want to teach you guys an acronym, okay, called the BFast, okay? And this acronym is basically created so that if you think that your parent, if you think that a family member, a friend, patient is having a stroke, you can kind of go through the BFast and see if they are indeed having a stroke or not, okay? When you're performing the BFast, what you're looking for is that there is symmetry between the left side and the right side, that they can do this, they can perform the same task. Whenever you see that there's asymmetry and that the right side is not being able to do the things that the left side is doing, then there's a problem, or vice versa, okay? So B stands for balance, because like I mentioned before, balance is one of those things that is almost always affected by stroke, okay? So you want to check the person's balance to see if they seem a little bit like off balance, or if they're dizzy. You want to check that, okay? E stands for eyes or vision, okay? You want to check the person's vision, because once again, most of the time, depending on where the stroke is, this person's vision may be affected by stroke. So maybe you want to put like your hands out and how many fingers do I have, or show them an object or whatever and see if they're able to point it out to you. If they're not, and there's some blurriness going on, there's some vision distortion going on, there might be something going on, okay? The next one, F stands for face, okay? Now, most of the times, depending on the type of stroke, you may see that their face is drooping to one side, depending on what side the stroke is, okay? You may see this kind of thing, that the person's whole face is almost like the face muscles has kind of lost its motor function to be able to keep the face together, that one face is literally drooping to the side, okay? Now, A stands for arms. And you want to check, what you want to do is that you want to tell whoever that you're testing to raise your arms up, okay? You can say, can you raise both of your arms up? And if they're like this, then that means there's something wrong, okay? If they cannot do both at the same time, then there's something going on, okay? S stands for speech. So you want to ask this person some questions to see, you can even say like, what is your name, to see if they'll be able to say it or speak as they normally do. If they are like slurring, their speech is a little bit slurred, or you can't really make sense of what they're saying, maybe they're kind of confused or something going on like that in that likeness, then there's definitely something going on that needs to be checked. T is for time, and I feel like T is the most important thing in this whole BFast thing, okay? Because time is of the essence, okay? And the reason why time is so important, you want to call 911 immediately if you feel like someone may be having a stroke, is the earlier that they receive a medical attention, the better, so that the stroke can be stopped, okay? Or can reduce or whatever. Because remember, the longer that this person goes without blood and oxygen to whatever part of the brain is without it, the worse the symptoms are going to be. Okay, so if you think that they're having a stroke, please get them help as soon as possible. If you are not there, and let's say that you are a parent or whoever lives by themselves, it's really important that you get them something like the Life Alert. And it's really important that you show them this video, or that you educate them about stroke symptoms, so that if they feel like they're having a stroke, that they can press this button and get help as soon as possible. Okay, another thing that I think that you have to be fast about, if you have experienced stroke already, is that you want to get therapy as soon as possible. it's really important that you start therapy as soon as possible so we can start working on you being able to regain back any kind of skills that you have lost because of a stroke. Okay? And the reason why therapy is so important is because the whole concept of neuroplasticity. If you don't know what neuroplasticity is, you should definitely do a lot of research on it, because I am like so in love with the whole phenomenon. So basically what that is basically saying is that our brain is able to adapt, our brain is able to change, because our brain is a muscle that it's not a static muscle. It's a muscle that can change depending on the input that you're giving it. So just like when you work out, just like when men or women work out their thigh muscles, your arm muscles or whatever, and over time you can see it, you can physically see the muscles are bigger, stronger, harder, firmer, whatever. It's the same thing with the brain. Neuroplasticity is saying that the brain is not static and it's not dead, or because of age or because of stroke, that if you get enough therapy and enough practice and doing enough functional activity, going back into that to therapy, that you will be able to regain some of the skills back, if not all. Okay? All the neurons and the synapses in your brain are weak because of a stroke or because of an illness, that those connections are able to become stronger, especially through therapy and through practice and doing the same thing over and over again, changing the resistance and upgrading it, and all that can literally build the brain muscle once again. So block practice and repetition is so important. That's why I think when people downplay therapy, I get so upset about it, because I feel like, one, they don't understand the importance of therapy. Yes, a doctor is needed to get you out of that acute illness, but therapy is needed in order for you to regain your skills again, for you to be able to go back to living the life that you want to live, period. I just wanted to go over quickly some of the risk factors of stroke. Number one on my list is definitely smoking, if you're a smoker. Okay? High blood pressure, which is another one. I know it's hard, especially when it comes to like stress, because stress does bring along high blood pressure, that you want to keep it at bay if you cannot get rid of stress. And if you need information on how to reduce stress, please check out my video, which is going to be up here somewhere, about how to reduce stress, because stress reduction is so important. Like, I know life gets hectic and it's hard to sometimes maintain your stress level, but you have to try. Like, you have to. Your body, your health depends on that. Definitely having high cholesterol is also not good at all, because like I mentioned before, the buildup of fatty substance in your arteries can get clogged up and you can get a stroke, because the nutrients and the blood and oxygen and everything travels through these arteries, and if you are clogging them up with fatty acids, over time the blood and oxygen, or all the nutrients, will not be able to pass through it to get to where it needs to go. If you have diabetes, if you have poor diet, if you use a lot of alcohol, and if you are inactive, meaning that you don't move around a lot, you don't exercise a lot, you sit there all day long and not move around and do stuff. Moving around creates circulation, which allow things to move along pretty well. So that's what my conclusion is about not being inactive and being more active. Okay, now to the fun part. Rehab, my favorite part, of course. Hello. What is occupational therapy's role in stroke rehab? How can OTs help? Of course we can help. Absolutely. Come on in. We got something for you. So most of the time when I have had stroke patient in the past, usually I start with the restoration approach, and to see what skills that I can restore back to the patient. And definitely along the lines, as time goes along, if there's skills that we have tried everything and we cannot regain back, then we can start thinking about compensating and modification, and seeing what adaptive equipment that we can use to allow the patient to still be as independent as possible. So one of the biggest things that I love when it comes to stroke rehab is definitely the use of some kind of ESTIM, electric stimulation. Okay, I have seen what it can do for someone with stroke. I have done it with my patient and it was amazing. He was able to regain so much back because of eSTEM. So if you don't have eSTEM at the facility that you work at, I advise that you would invest in that, because they have so many different eSTEMs now out there. They have ones that you have to do actively and some that you don't have to do actively, some that you have to do like while you're doing a functional task, for example. And it's like robots that you can put around your arm. It's so amazing. And I'm pretty sure those are expensive. But I have like the normal ones. And so, yes, eSTEM, which is a modality, is amazing for stroke. Amazing. And I'm going to try to talk about the deficits that I've seen with stroke and what we can do. So I've seen a lot of neglect. So basically these patients think that they don't have a left side because the stroke had happened on the left side of their body and they cannot move. They may or may not be able to move it, but they literally neglect the visual. So this is a visual thing. Like they have neglected the visual part of the, so if you put a line through here, they have literally neglected this whole side of their visual field, okay, and they only pay attention to the side. And so of course, if you have a patient like that as an OT, what you want to do is that you want to force this patient to pay attention to the left side. So you can purposefully put stuff on the left side and then have them reach over the left side with their right hand, for example, to grab a cup or a drink or something like that. Basically forcing the brain and retraining the brain to send synapses and send nerves and stuff back to that side that is blocking, that's causing that blockage. You want to deblock it, okay? And so you want, the more exercises that you're doing, the more you're forcing the patient to look on the left side and feel for things on the left side and reach on the left side. The more you're doing that, the more you're also retraining the brain to kind of come back. You kind of like basically stimulating the brain, like, hey brain, I have a left side, not just a right side. And the brain eventually, hopefully, can reconnect those wires almost. Another thing, like I mentioned before, that we work on as OTs is definitely balance. And balance in the form of, if you have a patient, your patient is going to need to have good sit-in balance. Number one, definitely good stand-in balance. Sit-in balance, even if they're sitting on the edge of the bed while they're working on their ADLs. If they're doing hygiene and grooming at bedside, if they're dressing at bedside. I know I dress at bedside sometimes, so I need my sit-in balance to be good in order for me to do that, because you always want to work from proximal to distal, okay? So you always want to make sure that the core is good, the trunk is good, because that's the only way that the patient is able to free up the distal extremities to do things. Okay, if that makes sense. So for example, if my balance on my core, my trunk is poor, it's going to be really hard for me to feed myself, for example, because this is not stable. However, if the first thing that I do as a clinician is to work on the core and the trunk and make sure that I have stability, then I can know the one that's safe enough and my patient will be able to move their hands to do things with their hands. Okay, I hope you guys can get that visual in your hand. I was trying to make it as simple as possible. And then of course, standing balance is also important. Once they have the sit-in balance down, now you want to move on to standing balance if the patient have these deficits. So all the things that I'm going to talk about is if the patient have these deficits. So standing balance, absolutely, is important. You have to stand to pull up your pants. You have to stand at sink. I stand at the sink every morning when I'm brushing my teeth, doing my makeup, doing my hair. I stand at the sink a lot. I stand in the shower to take a shower. So all those things are important. Standing balance is important for self-care and safety. And definitely you need balance to be able to transfer from one surface to the other, from bed to wheelchair. So balance all around is very important. Next, we're going to talk about vision. We already kind of talked about vision a little bit with the neglect, but definitely visual scanning, perception are all different things that you can work on when it comes to stroke patients with vision issues. Okay, another one that I see all the time is definitely a complete paralysis off the side, whichever side, that the patient is not able to move the arm or the legs at all. I mean, it's like paralyzed. They can't do anything with it. And the patient that I mentioned before that I did the e-stim on, that's how he was. He was completely paralyzed on the right side, could not move anything at all. So I was like, immediately, I was like, I need to start an e-stim on this guy. And he was able to move it. And so definitely arm weakness, you're going to see that a lot. You're going to see people who can't move it at all. So it's up to you to come up with different interventions to allow your patient to regain the strength back in their arms to be able to functionally use it. And definitely, like I said before, proximal to distal, work on the shoulders and then the elbow, and then move it down to the fingers to fine stuff. So gross motor and then to fine motor stuff. Okay. Cognition is also something that we can work on in collaboration with my speech people, because speech pathologists usually work on cognition, however, and kind of have a conversation about what their patient may be working on in speech, and to be able to have that carry over into OT. I usually ask my patients, like, what do you guys have been working on in speech? Because I kind of want to know, even though I kind of know what kind of cognition stuff they may be struggling with, so that I can also use whatever strategies or skills that they have learned and incorporate that into my session as well. But you can also definitely work on stroke stuff with them, especially when it comes to IADLs. If this patient has to cook or clean or do take care of a baby, or if they're a caregiver, anything like that, if money management, using a phone book, like all of those different tasks, you need cognition to be able to do it. Even dressing, you need cognition to be able to do it. You need to be able to know what side, where to put your arm, like which side do you put your head, like where is the front, where is the back, different steps, sequencing, you know, problem solving. A lot of stroke patients, depending on where the stroke is, will have a problem with a lot of these skills. So yes, you have to work on that. In addition to everything else. Another thing when I work on when it comes to stroke rehab, motor control, motor planning, is motor coordination, or motor control, you can say. Some patients, not all, have a problem with being able to have a fine movement of things. So for example, for me to, if I was holding a cup in my hand, for example, I can do a fine movement of taking the cup into my mouth and taking a sip, okay? Some patients, even though they may have the physical ability to hold a cup to their mouth, they don't have the fine movement, being able to do it in a very smooth, fine way. So that's something that you have to reteach your patients, okay? They may be able to move it grossly, like kind of like, but not really fine, kind of all over the place with it. So you have to teach them again to have that fine movement. Be able to have motor control, have control over what they're doing, okay? I had patients who have loss of sensation in their fingers, and they cannot feel, or sometimes they have tingling that's going on, which is basically means that they probably don't have enough circulation coming down. Another thing with sensation is definitely perception. Some patients cannot perceive items anymore, especially if their eyes were closed. So if their eyes were closed and I was to say, hey, what are you holding? And I'm holding a remote and I put it in their hands, they will not be able to identify what it is based on just feeling the remote, okay? They have lost their sense of perception, okay? Or, yeah, I could say, or maybe their memory of this, you kind of have visual memory of things, and sometimes you can lose that perception. So diagnosis, what I do with the patient is that first, of course, you have to test your sensation level and see what kind of sensation they have lost. And then depending on that, what I do with diagnosis is that I put different items in a bag, for example, and I either tell them to close their eyes, or if it's in something that's covered, I just have them reach into it and basically have them tell me what item they think that they are holding based on just feeling alone without using their vision, okay? And I will ask them, okay, how does it feel like? Can you tell me the texture? Is it soft? Is it smooth? Is it feathery? Like, what does it feel like? Is it hard? Is it spiky? Like, you know, have them describe different textures to you. And if sometimes there's a safety with sensations. If the patient is not able to feel hot and cold, that's a problem. If the patient is not able to feel sharp versus dull, that's also a problem, because they can cut themselves, especially if they're going to be cooking, for example. So it's good that you check all of these things and provide the necessary therapy that the patient needs so that they can be able to be safe, to be able to do the things that they need to be able to do once they discharge and go home. Okay, something that's good with sensory loss is also definitely e-stim. I think e-stims are good for sensory loss as well. Using vibration is also good for sensory loss. So just different things to throw out there. And also, if the patient is not able to sense pain, that's something that's problematic, because I want them to be able to feel pain, especially with people who have diabetes, for example. It's good for us to know that they have a wound, because if that wound is not treated properly, then they can possibly get it amputated. So everything is important. Literally, you can't miss a thing. You have to make sure you cross all your T's and dot all your I's. Okay, definitely self-care. We have to do self-care, like that's our thing, right? We have to teach the patient how to be able to dress again and do their daily activities, doing their grooming, being able to transfer and use their bathroom independently. All of those things are important, being able to feed themselves independently. So at that point, you have to do whatever it takes to get your patient to be able to do the things that they used to do. Definitely, if a patient is someone who have now is dominant in one part of their body, for example, if the right hand is not their dominant and that's the only one they have, we have to teach them how to dress one-handed techniques on how to dress themselves. So most of the time what I teach my patient is that you have to use the unaffected hand to dress the affected hand first, and once you get it dressed, then you can dress the unaffected hand. So these are all skills that you can teach your patients so they can be independent. Okay, using different adaptive equipment if needed. Definitely adapt, modify if need be, especially if you switch from remediation to a compensating approach. Two more things that I think is important for me to mention is, one, mirror therapy. Mirror therapy has shown to be really good when it comes to rehab. Another thing to mention is definitely mental practice or mental imagery. There's a lot of research on this and how good, not just for stroke but for any kind of injury, that a patient is able to imagine doing whatever it is that they want to be able to do, and that causes parts of the brain to actually be fired up as if the patient is actually performing that task, even if they're not. And then when they do go to perform the task, they're able to actually do it. So this is something that I actually want to incorporate a lot more when I'm treating a patient, to do some mental practice even outside of therapy. If you've tried everything and the patient has a contracture, then definitely look into splints as well. I personally don't like splints, because I feel like whenever I put a splint on my patient, it's almost like I have given up, and it's like, okay, I can do anything, so therefore I have to put the splint to prevent you from going to a full fist, for example. But definitely, if it has to be used, it definitely has to be used, so the patient is not, because nobody really do, especially when it comes to fists, like I feel like nobody really do anything with a fist unless you want to fight. But I'm just saying, that's the only thing that I feel like a fist is good for. Okay, and so if your patient has gotten a stroke so bad that they are in this position, you want to definitely put a splint on them, at least a palmar splint, so that they are not digging into their skin, for example, and that they're not stuck in this position. So definitely giving them a splint to allow them to eventually open up is good, but not just a splint. Use the e-stim, use other things to possibly, hopefully, get some kind of range of motion back. Of course, like I mentioned before, definitely work in collaboration with your speech and also with your PTs. Speech will be working on cognition, swallowing, and all that, and that's important when it comes to feeding. And you definitely want to work on PT when it comes to like lower extremity stuff and walking and all that. So that is the end of my video. I hope you guys enjoyed this. If you guys want me to do more on different diagnoses, let me know down below. Also leave links down below for you guys if you guys want to check out, you know, anything. As always, please make sure that you subscribe, okay? Please subscribe, okay? Come on. just do it. It doesn't cost anything. It's free, literally. It's free. It's the only thing that's free in America, I promise you. Just go ahead and sign up and join the LovellyOTS family, okay? And yes, as always, thank you guys so much for all the love, all the support. I love you guys so much, to the moon and back. And see you next week, okay? Please like, subscribe, comments, and as always, I love you guys so much. Bye.